What I want to do now is have Josh talk for a couple minutes about this whole concept of provider service networks and having these provider-led plans compete on a level playing field directly with commercial HMO plans, and then talk a little bit about the politics of it and open it up for questions.
Thank you, Karen. And I would just start my brief remarks here by saying that I know that a lot of hospital folks are nervous about this, and we really apologize that it didn't work out to hear from some of the providers in Florida. If you'd like to talk to some in Florida, please come get my card afterwards, and we'll put you in touch with them. We do think that this is a really important conversation to hear from peers in other states that have gone through this. So just wanted to take 1 second to highlight these provider service networks, which really are a unique aspect of the Florida reform, and I think adds a whole new twist into what can be a competitive and additional choice for these consumers. And I will just highlight one thing, which is in Florida, given all of this choice, they do have choice counselors, so that there are individuals that are able to help beneficiaries to determine what is the best plan for them, whether it's a PSN, as we often refer to them, or whether it's an HMO. So just to give you a brief snapshot of what these can look like and why some of the providers were so happy to participate. I think the main one is that for them it was an ability to coordinate care. They've been struggling for years to be able to do this in the Medicaid program, and this gave them an opportunity to do so in a very new way. It was also an opportunity to provide services to patients that they wanted to provide for years but haven't been able to. And Karen gave an anecdote here, which I think is really telling, which is at the hospital that was going to speak with us today, with HMOs before, they basically came to an agreement to put a case manager in the ER just to deal with Medicaid patients that were coming in. They had to get to that point where they hired a case manager. Under their own PSN, they're able to design whatever system to set up to be able to make sure that Medicaid patients are getting the care that they need and not always showing up to the ER. I think finally it allows them to pilot things much more easily. They don't have to get prior authorization from plans for certain things. They can go ahead if they think it's going to help their patients. And for them, there's a lot of freedom in that. What are PSNs? What do they look like? Well, some of them are doctor-owned and run, and some of them are hospital-run. So they look differently. They look different. But I think there are a few kind of basic principles which we pull away from Florida. So that's the first one, they're provider-driven. The second one is that in the beginning of the program, they were paid a fee-for-service with a shared savings element, and they were given a per month base fee for administrative costs. It's very predictable going forward. And then finally, there was a requirement to report some quality or the outcomes, so we actually knew how Medicaid patients were faring at the county level. So those were some of the unique characteristics of the PSNs. As far as how did the choice work out in the first few years, the University of Florida has done some work in evaluating how the PSNs have done versus the HMOs. In the demonstration, they started as a pilot in the demonstration counties versus the non-demonstration counties, and I think it's very telling about the cost savings that we previously talked about. But as far as the choice, you can break it into two populations, the SSI population and the TANF population. Initially, for the SSI population, it was about a 60-40 split, 60% with HMOs and 40% with PSNs. And for the TANF population, it was 70% HMOs and 30% PSNs. I think we'll continue to see whether folks feel like they're being well served in changing plans if they don't feel like they're being served. So as far as the that University of Florida study found, just to give you a sense for the savings here, and these numbers sound relatively small, but I think are very telling. So for the SSI population, in the non-demonstration counties, costs went up $2,200. In the demo population, per member per month, excuse me. In the demo, it's $480. So you see that contrast. In the TANF population, up $333. In the non-demo counties, up $12 in the demo. So there has been a shifting, if you will, here in the amount of savings that are able to come from it. Previous studies have shown that folks are really happy with the quality of care that they're getting for the PSNs, and I think that's it's given some validations to the hospitals that have gotten involved in this. And then finally, the speaker mentioned this earlier, that a lot of these PSNs are moving towards some sort of capitation or full capitation going forward. And for them, they feel like this is the direction that they would like to move anyways, and this is a good opportunity to be able to do that for the Medicaid population.
So Dean, talk to us about the politics of these provider-led plans, because certainly it would seem like a lot of the commercial HMOs might not like that additional competition element. From your perspective as a policymaker, why was that piece important, and how did you work with the provider constituencies?
Well, it was important because if particularly from the physician groups and the hospitals, it was a legitimate complaint to say, we're concerned about being disempowered vis-a-vis the health plans. And one of the ways we do it, and I said, look, we will make a way for you to compete. If you want to provide a particular region, we will create an avenue in the system for you to compete, both by writing it into the statute and by giving a couple of safeguards in the actual process of implementation. One of which was we required that anyone who wanted to bid on a region, any one of the plans or the PSNs, had to negotiate with the providers in that region, the docs, the hospitals, the other specialty care providers, rates, and that gave basically the power advantage to the docs and the hospitals, which they didn't have to agree to a rate on the front end chosen by a health plan. Once, and if they didn't agree to provide a rate to a particular plan, that plan would be at a disadvantage when they went to bid on it with the state. Once they agreed on the rate, though, then they had to provide that rate, and they couldn't renegotiate the rate with the plan. So then it required them not to try to renegotiate the rate during the pendency of that 5-year plan, except for inflation increases and sort of non-discretionary increases. And it essentially reassured them that, hey, if I'm a hospital, if my interests are from the hospital perspective or from the doctor perspective, I'm not going to be held solely to the mercy of the HMOs. It made the HMOs motivated to negotiate a good rate, a favorable rate that the hospitals and the doctors would agree to on the front end, and then serve them. But at the same time, it then prevented anybody from backing out after the fact and ultimately either upsetting the economics or denying health care to the Medicaid enrollees. And that's sort of meant partially what I meant at the beginning, which is nobody got a clear win. No one group got everything they wanted. Any one of the groups would have wished they could have made a few tweaks to the system, but when everybody's equally unhappy but everybody's relatively satisfied, that's probably a decent political solution. And that was the measure that we used, and it actually played out that way in the political process.
We have time for a couple questions from the audience before we move to our next panel talking about the evolution of managed care. If you have a question?
This can't be a shy group.
They weren't shy when they met with me.
If you can just state your name and affiliation.
Sure. Amanda Lavin, Society anesthesiologist. And I have a question. You all talk a lot about reduced costs, and I certainly understand that. And I'm curious what your patient outcomes have been since you have switched to this system. And I'm particularly curious how you measure that, because I heard the speaker say that initially you had no information, that's no outcomes when you started. So you didn't really maybe have a good basis where you started. How did you measure where you come to determine if you had successful patient outcomes?
Well, it's fair to say we don't know for sure that they weren't getting stellar care back before we did reform, but I'm pretty sure they weren't. We have in the contracts that the state wrote with those who wanted, and in the bid specifications when they offered the procurement, we said that the plans or the PSNs or whoever it was that was going to be providing care in a particular region had to adopt and use industry measures, and I can't remember the acronym, but it's like the HEDIS score, the STAR score. They're measurements of healthcare performance that are sort of nationally recognized as indications of quality of care. We actually put that when we did the invitation to negotiate for any of the providers or plans that wanted to serve a particular area. We said contractually, you're going to be obligated to report these on a regular basis, and we're going to track them and see that whether they're improving. And so no one has called to say, boy, we got better care under the old system. So I can only tell you it's anecdotal, but we now know what it is region by region, what it is between providers, so you know who's doing a good job providing care, who isn't, and and we set the ITN up so that the contracts would automatically expire every 5 years, but the state could terminate for cause anytime one of them fell below certain standards. So literally, whatever provider has a particular region is and should be terrified of failing to meet those standards, because they can lose all the investment they've placed into that region, and that population can leave them in the midst of it.
There's also an annual by-plan consumer survey where they ask questions about access to care, your interactions with the plan, your satisfaction with primary care, specialty care, hospital care, how quickly you could get an appointment, questions like that that are again publicly reported. And as Josh talked about, those independent third-party choice counselors, they have access to that information and can also inform patients. So as patients are looking at several different plans, the choice counselor can talk about this plan does a good job with diabetes management based on their HEDIS scores and how those track over time, and also consumers are satisfied in this way. So the ultimate measure is patients can vote with their feet and drop a plan each year and go with another one. So there's that accountability, as Dean talked about, with several different plans, but there's also industry standard reporting on health outcomes as well as consumer satisfaction that are publicly made available, and then the state tracks and puts out in a very transparent way over time, so you can see those differences and compares them to the national averages. Well, we'll now move to our next panel. Thank you.
I think what we'll do to try to keep going on schedule, we don't want to cut the next panel short, but what I would like to do is we've asked several of the plans to speak today just about how they've seen managed care change and how they're working with provider groups to make it a win-win for those involved. So at this time, why don't the providers that are on the agenda to speak, why don't you come up here, and we'll start with Frank for Aetna, and then all three of these mics are live. So, and kind of our format for this session is we want each provider, or we want each plan to be able to discuss, their particular expertise, how they saw it, how it's worked in the state they're in, and then move to the next plan, and then at the end, have it open for questions.
Good morning, everyone. As you may know, we have been given 5 questions to respond to, and so I will go through the 5 questions and give you our quick response. Clearly, any of us could talk hours upon hours on each of these, but in terms of brevity and making sure that all of us have the appropriate time, to respond. I know that I'm going to be keeping my quick comments to about 5 to 7 minutes, so there's time to also ask questions and allow my peers and colleagues to answer them. The first question is, what experience do you bring over the standard Medicaid program that improves health outcomes? Excuse me, I do need my glasses. Aetna has been in what we refer to as the Medicaid space or business for over 28 years. We've worked in 15 states, and we have an excess of 2 million members in our Medicaid plans. And why that's important is when we're in a state and when we're working with our organizations, it's not just a risk plan that's based on a contract with a state, but we also have gone into partnerships with provider organizations where they may be the person or entity that is contracting with the state, but then they have hired us to be their back office and do the things that we do really well too, which is pay claims and do all of the reporting and things like that. But we do have risk plans in most of our states and have those provider support organizations in 3. We have an integrated care management program that aligns population management concepts with the needs of the individual. So basically we can take a look based on past claims and history in terms of what is going on with that individual member, and then look and check and discuss their behavior with them. And what I mean by behavior is basically this is how they've gotten their health care in the past, this is what they've done, and maybe they don't understand the system, what kind of health outcomes we need to be working on, and then start directing that. We firmly believe in a true integration of behavioral health, physical health, and the psychosocial needs of our members. That helps ensure that we are then removing inappropriate and duplicate care as it reduces the members instead of receiving the coordinated care at the right place, the right time, and which truly does tend to be more cost effective. Our care, and I'm sure all of my colleagues will say the same thing, we do this, we are all member-driven, member-centric in our delivery and member interaction. One of the things that we also do, which is a little bit different, is we actually locate our staff in the communities of the members that we serve. And we do have the experience, as I said, over 28 years with the most complex, highest need beneficiaries, including dual eligibles, individuals with multiple disabilities, and this 28 years experience allows us to provide the citizens and the Medicaid beneficiaries of Oklahoma with some true experience in helping them to achieve improved health outcomes. Second question was, what innovative solutions do you employ to reduce costs? Again, I've talked about the integrated managed care approach. Again, if you're truly going to measure expense, you've got to take a look at what your costs are on a monthly basis. We have a report which we call the monthly category of expense, which reviews trends and reports any kind of outliers. Our collaboration with the providers is to reduce the unnecessary cost, so that if I'm going to my primary care doctor today and he or she sends me to a cardiologist, but my primary care doctor took the x-ray, make sure that that x-ray gets to the cardiologist so the cardiologist isn't duplicating some of the same tests, and that information is shared. And most important for us is working with the member and making sure that that member has reminders about their appointments, that with our case managers and care managers, that we establish and set goals for the members, step by step. It's kind of like when you want to lose weight. You give yourself a goal that we want to lose 50 pounds, but you're not going to lose that weight, within that short, within that time period. So you cut it off in incremental time periods. And so we set those realistic goals with the members for their care and helping make sure that they understand it. And then we monitor it. We monitor with them through our case managers and our care managers and through the community organizations that we work with in our states. And then last but not least, and most important, is education, helping our members understand why. Why is this important? Why is it important to go to your doctor if you have diabetes? Why do you need to have these tests done? What are the kinds of outcomes that you should see? Again, helping them set the goals and actually having that image and that picture so that they can know what success is. And then we also talk about what we call scoreable action items, which is basically each of our plans in each of our states takes a look at those costs and says, with our members and making sure that they are getting the appropriate levels of care, are we providing these cares at what could be the best cost to our members? And that's through our own contracting with durable medical equipment or any of the other kinds of services that we're contracted to provide. Third question was, what solutions do you implement to decrease challenges such as improper emergency room use, decrease improper readmissions, and encourage effective pharmaceutical use and counsel patients towards better health? One of the things that, again, as part of our reporting is what we refer to as our core report, which is a consolidated outreach and risk evaluation report. This helps us, again, identify our members, what they're doing, how they're seeking health care. Are they following the plan that we all set out for each other? Are we working in line with the guidance and the principles that the state is trying to achieve in terms of better health outcomes? Again, we use predictive modeling and evaluate risk of future use of the emergency department. If we take a look at my claims and that I've been to the emergency department 24 times in the past year, we can basically say that if I don't do some kind of intervention or someone doesn't do some intervention, that behavior is going to stay exactly the same. So what is it about Frank that has him seeking going to the emergency department and not going to his primary care doctor? Is it possible that he doesn't understand how primary care works in the use of urgent care centers? Is it possible that Frank is a working parent and can't get off work between the hours of 8 and 5 because I'm in a hourly paid job, can't take off work, and I need to use and access services that are available to me? So, and then that's when we talk about aligning incentives with provider organizations, and I'll talk about that in a second. And of course, this process, these programs, we can demonstrate do work. Through an independent study at the University of Illinois Chicago in the first year of our integrated care management program in Illinois, which recently started, we reduced emergency department utilization by 6.9%. We decreased high frequency of emergency department utilizers by 39%. We decreased ER hospitalizations through the emergency department by 15%. Makes sense. If they're not going to the emergency department, they're not being there that frequent, so they're not going to be admitted into the hospital. And then we decreased overall hospital admissions by 18%. And again, we're always making sure that we're working with and identifying who the high-cost utilizers are and how do we make sure that they can be seeking care in the most appropriate manner. How can you ensure that your plan coverage to both rural and urban areas? We recognize that 25% of the U.S. population in the United States is in a rural area, with only 10% of the physicians in the country that are practicing in these areas. So we know that we have to do a very good job in making sure that we're coordinating care. Of those 15 states in which we have health plans, 5 are in highly rural populations: Nebraska, Kentucky, Pennsylvania, I'm happy to say the state of Florida, and the state of Missouri. We develop partnership networks with state agencies, not-for-profits, along with our providers, because we know that faith-based institutions and not-for-profits and educational institutions are also a great source of education and information to the population that we get to serve. And we always have broad participation amongst our provider network. It's a very, very stable network of providers where we align incentives and pay for performance. And the last question was, how can hospitals, doctors, and other providers win from moving to more coordinated care models? And do you have specific examples? First and foremost, this isn't going to change, and I think our previous speaker said, if you're really looking at trying to improve health outcomes and if you're trying to decrease costs, you just can't do the traditional and fee-for-service payment methodology that we all have seen and experienced. So at Aetna, we align incentives with our providers. We look at the goals, we look at the health outcomes and say, what is it that we're trying to achieve? And are there things that we can do, because we know how important the provider community is in making all this happen, and they're literally foremost in that process. So do we incentivize doctors to stay open past 5 o'clock? Do we incentivize doctors to have staff that are bilingual? Do we incentivize doctors to help us achieve those HEDIS goals that our previous speakers were talking about, which are national standards? Part of the problems in the past is that we were all on, many years ago, on capitated arrangements, which basically meant we paid providers so many dollars per member per month, and they didn't have to provide reporting. Well, if you don't have the reporting, you can't say that you're meeting these HEDIS measures, which made us look pretty bad as an industry. We also have a lot of shared savings and pay-for-performance programs, and we do that in 19 of our states right now. And basically what that means is, as we look at medical costs, if medical costs are dropping, and I'll use an example of a whole dollar, if we're paid $1, then we need to be making sure that some of those savings are shared to the physician. We have long-term care programs in many states, and we also look at patient-centered medical homes. I can talk a lot more, but I'm going to pass it on to my next colleague. Carol?
Thank you. Good morning. I'm Carol Steckel, and I am a Senior Policy Director for WellCare Health Plans out of Tampa, Florida. and also a former Medicaid director in a couple states and working with the Department of Health and Hospitals in Louisiana. So I've looked at this issue from both seats, and it's been an interesting perspective. Rather than answer the specific questions, what I would like to do is take the prerogative of the microphone and say what I want. So, managed care, if you look at both from the Medicaid perspective and from managed care and from each of our perspectives, whether you're a hospital or you're a doctor or a specific type of doctor, if you think about when Medicaid was formed in 1965, we basically, if you went into a hospital, you either got well or you died. That was the medical care model then. Now, fast forward to today, now you have people surviving with cancer, you have people with chronic illnesses that before they would not have survived. The type of healthcare services that we have to provide as a healthcare industry is very, very different. And my colleague who talks about coordinated care, integrated care, we cannot emphasize that enough, whether you're a hospital, a managed care company, a physician, or different types of physicians. So you're seeing that evolution in the healthcare system itself, and what is happening is the industry behind how we cover healthcare services is having to change. So you're seeing companies like those of us represented here, you're seeing health plans, whether they're physician or hospital oriented, starting to look first at the whole person. You cannot separate a dental service from a physical health or mental health from physical health anymore. I used to talk about aha moments as a Medicaid director, and the idea that you separate behavioral health from physical health. We all know that that doesn't work, but that's exactly how we designed our healthcare system. You've got to bring all of that back in together. You also have to look at how you hold everybody in the system accountable. If you want behavior, you drive that behavior, and you can drive it in very many ways, through a contract, through financial arrangements, through partnerships, and we can't do our work here without having partners in the community. A health plan can't move into a community and do its work without the physicians, without the hospitals, without the patients that we take care of. So that is all part and parcel of what we're all dealing with, and the desire to say, I don't want to change is great, but if we don't change, the system will not continue. And I worry about Medicaid programs who, you know, as a Medicaid director, as a health plan employee, what a great honor I have every day to think about the work I do, the work that the Medicaid people that I've worked with before do. That improves somebody's lives, and that's an awesome responsibility and an awesome honor, and one that we've got to break out of our silos and take to heart. So one of the things, you know, certainly we all probably have very comparable types of integration programs, but I'd like to address the quality issue that was raised in the question and give you some very real statistics about a program that we have in Kentucky. As many of you may know, Kentucky implemented managed care for the first time, I believe last year or the year before. There were some bumps in the road, and that's something that you all need to understand in Oklahoma, is that, and you'll hear from the state representatives that have done this, it's not an easy road to take, and there will be mistakes made on the state's part, there will be mistakes made on the plan's part, and there'll be mistakes made in the government's part. So you have to learn from both the good stories and the bad stories that you hear nationwide and build your program that protects Oklahoma's citizens and residents. So in Kentucky, our plan in Kentucky, the performance measures that I'd like to talk about, particularly vaccination rates, for chickenpox was up 4%, preservative-free flu vaccines for children up 33%, the HPV vaccine up 14%, and the influenza B vaccine up 9%. But here's where the statistics get even more moving. Performance measures, and one of the things I advise everybody to do, hold us accountable. You know, all of us are 5-year-olds at heart. If we can push that envelope, we're going to do it. Not that our company does it, or I'm sure any of you all do it, but you have to hold everybody accountable. We have to know what your expectations are, and you have to know that we're going to fulfill those expectations. Performance measures for Kentucky Medicaid, and this data comes from the secretary of the department in Kentucky. Diagnostic screening processor results up 1,079%. Therapeutic, preventive, or other interventions up 1,938%. Mammogram assessments up 4,538%. Think about that, mammograms up 4,000%. Hemoglobin A1C documented, the test for diabetes up 169%, and blood pressure documented up 107%. Now you think, okay, so now we know everyone's hemoglobin A1C. What does that mean? Well, what it means is someone gets into care and gets services to either alleviate diabetes or to treat diabetes. So what statistic matches that? Amputations are down 17.18%. Those are the kind of statistics that you see with a coordinated care model and integrated care model that managed care plans provide in states. And then I'd also like to talk about people. One of the earlier speakers, I think the speaker talked about the goal, my goal and our goal in working with the individuals that are part of our members is how do we get them back into the community? How do we empower them to take control not only of their health and their physical health, but to be able to get back into the community either as an employed individual or as an active social individual into the community. So we're very excited about a program that we call Health Connections, and I want to give you two sample cases of what this means for individuals, and these are both in Kentucky. And then I'm going to talk to you very, very briefly about a young man that I have absolutely fallen in love with. My husband hates it when I say that, but it's true. So we had a woman that was an individual with a disability. She broke her back, fractured her vertebrae. She wasn't able to drive, wasn't independently mobile, but she had a bachelor's degree and she really wanted to work. So we did the assessment, we worked with her, and we found out that she needed connections to the LIHEAP program for heating and energy. We hooked her up with Meals on Wheels, again, community services. We got her involved connected with non-medical transportation. What we found out is she didn't have a support group, a social support group. She didn't have employment assistance, and we put her in touch with community programs that could do that. Worked with the local Center for Independent Living and identified a social support program for her, and we created an employment plan. Now think about this, a healthcare managed care organization helped this woman create an employment plan, again with goals so that she could achieve them and then get back into the workforce, and she was able to do that. Another example of what we can do that a lot of managed care companies or a lot of Medicaid programs can't do is work with the non-member families. So in this case, we had a homeless family of 3 seeking emergency shelter. And the father was a retired veteran who wasn't able to work. The mother was trying to find part-time work but wasn't able to. And the son was struggling at school and has emotional outbursts. So the child was one of our members. What we were able to do for the whole family is to find housing assistance, financial and shelter assistance. We got them into family counseling and support services, employment assistance, and then support in the school system, the IEP system for the child. We worked with VOC Rehab, got the mother and father into employment training and placement programs, identified counseling programs for them and for the child, and worked with the local school program. So it's not just health when we talk about health and behavior and we talk about social services. It's the whole social determinants of health, which is the new buzzword. But we have found that if you don't address those issues, no matter what you do on the health side, you're still going to be spending a significant amount of money. And, excuse me. Last but not least, I want to tell you about a young man that I am absolutely, madly, passionately in love with. And Taryn introduced me to him. He's actually one of our members, and he's given us permission to talk about him. So for the HIPAA lawyers in the room, I have permission. But Moise Brutus is a young man, 23 years old. He was in a horrible motorcycle accident when he was 18, 19 years old, lost both of his legs and part of his arm. you know, could you imagine if that happened to you at this age, much less when you're a young person at the height of your life? And he went through the depression period. It was very hard for our case manager to get to him. Finally got to his mother, who got to him. And let me fast forward to where he is now. One of the issues he had as a young man is the artificial legs that we gave him would break because he wanted to do active things. Well, under the traditional Medicaid program, there's a list of things that you can get, and it's very hard to get things done other than what's on that list and approved. Well, the leg that he was approved for is $30,000. The one he really needed was $90,000. Now, it doesn't take a math genius to figure out that if the kid breaks the leg twice or 3 times, you're already spending that. And his quality of life was horrible. We invested in the better legs for him, and we're able to work with him on a variety of other issues. So we spent the $90,000, got him his better leg, and he now is training for the Paralympics in bicycling and has now been accepted in college and is training for bicycling in the Paralympics. The kid is amazing. If you ever get a chance, if you go to our website, we have a video about him, and FGA does too. But the inspiration, but that's what we're about, is not only how do we get someone physically healthy, mentally healthy, and how do we get them to live the highest practicable life, excuse me, I can't say that word very well, in the community at the levels that they can. That's what we're about, and that's what we have the flexibility to do, where even Medicaid programs as advanced as your program here with the Healthcare Authority, they're not as nimble, and no Medicaid program is as flexible in a timing way as a managed care organization and the partnership of the providers in the community can do.